Alright guys, today we're going to be covering Chapter 8, the initiation of mechanical ventilation in Chang's Mechanical Vent book. The 4th edition of it starts on page 212, so let's get into it. So, we're going to be covering the goals of mechanical ventilation, the 4 major indications and their clinical signs, the contraindications of mechanical ventilation when not to do it, initial ventilator settings once you have it hooked up, initial ventilator alarm settings, and also we're going to name some of the hazards and complications of mechanical ventilation. Now I know that seems like there's only a handful of things here that I mentioned as the key points, but trust me, there's a lot to cover. So, starting with the goals of mechanical ventilation. What is the point of mechanical ventilation? Let's say to improve gas exchange. Why would you need that? Maybe the patient is hypoxemic, so you need to improve gas exchange to reverse the hypoxemia and relieve the acute respiratory acidosis that they could be in due to not ventilating, hence the need for a ventilator. Okay, one of the other goals is also to relieve respiratory distress, to reduce the oxygen cost of breathing, because you breathe normally, it uses up oxygen. If you're in respiratory distress, your work of breathing is increased and you're using up a lot more oxygen than you normally would be. And since you're using up a lot more oxygen using your accessory muscles to breathe, you are also going to eventually end up in respiratory muscle fatigue. You're going to be tired of breathing so hard for such a long time, you will end up slowing down your breathing, which will put you in the respiratory acidosis and impending respiratory failure. One of the other goals is also to improve pulmonary mechanics, to prevent and reverse atelectasis and improve compliance and prevent lung injury. That one is pretty straightforward. Another goal is to permit lung and airway healing. Maintain lung and airway functions. Surgery. That's the biggest one. Go into surgery for, let's say, a liver transplant. I don't know where I came up with that. Don't ask. So in order to prevent any additional complications of the lungs, we put them on a ventilator because obviously they're going to be sedated and all that jazz. Let's see. Another goal is to avoid complications. Like I just mentioned, protect lung and airway and prevent disuse respiratory muscle dystrophy. You're under sedation for a long time. The mechanical ventilation is doing all the work. Your diaphragm isn't used to you working it. It's just the use of negative pressure and positive pressure to push and pull the diaphragm. So it's not really exercising. It's like if somebody made you put your arm up and down for like several hours a day. You're not really getting exercise. Even though technically your muscles are working, you're not getting any exercise. So same way to prevent any kind of dystrophy due to that. Okay, those are all the goals, and I'll have them listed somewhere over here or somewhere over here. I don't know yet. Okay, now let's go to the 4 major indications of mechanical ventilation. Why do you need to put them on a vent? What happened? What changed? Looking at the name mechanical ventilation, it's what it is. Mechanical ventilation. They're not able to exchange the gases to get the CO2 out. So you need to do that for them. They need additional help with that, or complete total control of it. Okay, so if they're not able to get the CO2 out, they're in acute ventilatory failure. They cannot. Zero. Zip. Zilch. That's clinically defined as the PaCO2 greater than or equal to 50 millimeters of mercury with accompanying a pH of less than 7.30. Let's see. Other signs include apnea, bradypnea, acute lung injury, ARDS. For COPD patients, the PaCO2 criteria is increased due to their air trapping. So whatever is a significant increase above their baseline would be their criteria for acute ventilatory failure, I'm sorry. Okay, another indication is impending ventilatory failure. Now, if they have increased work of breathing, their blood gases are marginally normal, not so great as you'd see with a normal person, or not to the point of complete ventilatory failure, that is clinically defined as impending ventilatory failure. Now, in impending ventilatory failure, the CO2 may be normal or low due to them breathing so fast. If you're breathing a lot faster than what you normally would, you're blowing off the CO2, you're not able to maintain your CO2 levels, so preliminary ABGs might show respiratory alkalosis, and then as the ventilatory failure worsens or you can't keep up with the work of breathing, you slowly become bradypnic, I guess, and your CO2 shoots through the roof. Now, for any other causes, if they're in impending vent failure and the underlying cause is not fixed, then they will go into ventilatory failure, acute ventilatory failure. Again, the respiratory muscle fatigue, which leads to an increased PaCO2, and increased PaCO2, since CO2 is an acid, will drop the pH to the acidic range less than 7.40. Now, that poses the question, how do you know if the patient is in or going into ventilatory failure? How do you know if they're an impending vent failure? Let's see. You would have increased work of breathing, and since the metabolic needs are solely dependent on the work of breathing, how much oxygen you get and how much CO2 you expire, is solely dependent on the lungs. You can measure lung functions to know if they're in impending vent failure. Let's see, you can have tidal volumes of less than 3 to 5 milliliters per kilogram. Your frequency and pattern, you have your rapid shallow breathing index. They're breathing really fast, they're breathing really shallow. Greater than 30 respiratory rate per minute. You have labored breathing, irregular breathing. Again, that goes back to increased work of breathing. Your minute ventilation, since you're breathing so fast, your minute ventilation will be up. It'll be greater than 10 liters per minute. You can also do a vital capacity at the bedside parameters. Your vital capacity would be less than 15 milliliters per kilogram. Your maximal inspiratory pressure, if they're in vent failure, they can't have that inspiratory pressure to get the air in or exchange the CO2. So therefore, their MIPS would be, or NIFs, negative inspiratory force, which is what it used to be called, would be less than negative 20 or less than negative 25. So anything more or less or higher, for example, less than negative 25 is the criteria. So anything like negative 10 would be worse. Got it? Okay. You could trend the PaCO2 via entitled capnography, or you can do ABGs. Any way to trend the carbon dioxide, you would know that increasing carbon dioxide levels in the blood would indicate respiratory failure. You can also look at their vital signs. If they're breathing really fast, their heart rate would be through the roof, their blood pressure would be increased, they would show signs of distress, diaphoresis, sweating. So that's how we'd know if they're in impending ventilatory failure. Okay. Another indication is severe hypoxemia. Severe, very bad. Hypoxemia, oxygen in the blood. Very bad levels of oxygen in the blood. There we go. That would clinically defined as a PaO2 of less than 60 at a FiO2 of greater than or equal to 50%, or a PaO2 of less than 40 at any given FiO2. Even if they're on 100, but their PaO2 is only 38. It's not good. You need to do something about it. Now that could lead to shunting. I mean, it could indicate shunting, why they're severely hypoxemic. You got to figure that out. It could be due to acute lung injury. They could have acute respiratory distress syndrome, ARDS, pulmonary edema. You could have carbon monoxide poisoning. Those are all examples of where mechanical ventilation would be needed solely for the purpose of oxygenation. Now, how would you figure that out? What's causing the hypoxemia? Is it ALI? Is it acute lung injury? Is it ARDS? Is it pulmonary edema? You do the test, because ALI and ARDS and pulmonary edema have similar characteristics to an extent. So you do the pulmonary capillary wedge pressure. If it's greater than 18, then it means you have pulmonary edema. You got something building up. You have swelling in the pulmonary vasculature, which is increasing your pulmonary capillary wedge pressures. If it's lower than 18, then pulmonary edema is ruled out. You just throw it out the window. That's not it. Now, then you have acute lung injury and ARDS. Now, in acute lung injury, if your PF ratio is the PaO2 divided by the fraction of inspired oxygen, and if that value is less than or equal to 300, then you have acute lung injury. But if that value is less than or equal to 200, then you have ARDS. ARDS is just a very severe, you're not able to oxygenate due to not being able to ventilate properly to have that gas exchange occur. The final indication for mechanical ventilation is prophylactic ventilatory support. When could we use this? Let's see. To reduce risk of pulmonary complications in cases such as prolonged shock, head injury, smoke inhalation, or if we need to reduce hypoxia of major body organs in conditions such as hypoxic brain, hypoxia of the heart muscles, or if we need to reduce the stress on the cardiopulmonary system in cases such as prolonged shock, coronary artery bypass surgery, other thoracic or abdominal surgeries. Like you'd think, oh, they're going into surgery, let's put them on a vent to prevent further complications of the cardiopulmonary system or prevent stress of the cardiopulmonary system. Now that we've covered the indications as to why we should put them on a ventilator, let's cover why we shouldn't put them on a ventilator. Contraindications of mechanical ventilation. The absolute contraindication of mechanical ventilation is a untreated pneumothorax. Untreated means there's no chest tube in there to drain the air that's built up, because you have air, and then you have your lungs. If you're inflating the lungs, it's just going to push that air into the chest wall, and you could have a chance that significantly increases your chance of either popping the pleural space or just causing a lot of trauma internally. So that is an absolute contraindication. If the patient doesn't want it, if the patient's family refuses, you get a doctor, be like, hey, talk to these people, or you talk to them, figure it out why they don't want it on there. It could be due to personal reasons, private reasons. They could not want to tell you. You have to respect their decisions, because the patient has a right to withdraw or stop any treatment at any time, regardless if it's helpful for the patient at all. Another contraindication is medical futility. If there's been studies for X disease that mechanical ventilation does not help at all, and there is a certain criteria, be like, okay, 50 or 100 studies have successfully proved that for this disease, for disease X, mechanical ventilation is no use. It does not help at all, no matter what you do, what settings you put it on. So that medical futility, it's futile to even try that. But you as a therapist, as part of the team, you can talk to the doctor. Maybe that patient's condition is different than the 100 or so studies that were done. So it just depends on the doctor, the nurse, and the therapist themselves to figure out what the best way is to treat condition X for patient X. Let's see. Another contraindication goes back to the patient's informed consent. If they have lung cancer, for example, and they're on their last, few months, years, they don't want to prolong their life, because being on a ventilator is not the greatest quality of life. And if the person themselves or the family decides for them, okay, they've suffered enough, we want to end the pain and suffering for her or myself, if it's the patient talking, then that is a contraindication. It goes back to informed consent. If you do it, it's battery and all that jazz. Okay, so once you figured out you need a mechanical ventilation or you don't, you start it. What do you set it on? What are these magical settings? Now, there's a disclaimer here. You go into a hospital, you see a ventilator, your family, friends, they're on a ventilator. I hope to God they're not. But if they are, and you've seen this video, but you're not certified in any way, do not change the settings. I repeat, do not, please. Now that's over with. Let's go to the initial ventilator settings. Alright. We have you have your mode, your frequency, your tidal volume, your fraction of inspired oxygen, the FiO2, you have your IE ratio, you have your flow pattern, and then you set your various alarms. So let's start with mode. Normally you start off a person, you can either have full ventilatory support or partial ventilatory support. Full would be they can't do any of the work. Partial would be where they go to surgery, they come back, They can breathe a little bit on their own, but they only need partial. They don't need it for an extended period of time. They're only using it for a limited time, and they can, as the name suggests, partial. You're only giving them a little bit, you're letting them do the rest. You're just a support system. Okay, your full vent support modes are assist control and SIMV, which stands for synchronized intermittent ventilation. Then your partial vent support modes are the bi-level positive airway pressure, BiPAP, or the PSV pressure support ventilation. Then you have your dual control modes, such as volume control ventilation and pressure control ventilation. And if you have both of those together as in a dual mode, your breaths are volume targeted, pressure limited, and time cycled. There's a lot more going on than just a single mode ventilation. Your patient comes in, they need full vent support, put them on AC mode. You start to wean them, go to SIMV, then if they can make all the breaths on their own, you go to spontaneous. We've covered the weaning parameters already, so I'm not going to go into that. Now we go into the frequency. Frequency is rate, how fast they breathe in a minute. Normally 10 to 12 breaths per minute. Anything greater than 20 breaths will lead to a insufficient expiratory time and lead to air trapping, which will cause auto PEEP. If you can't get all of the air out in the time that it's supposed to be cycled through, then you're going to have air present inside, which is exactly the same as PEEP. You will just have an auto PEEP, as they call it. Right. The alternative method to figuring out the frequency, you can do the estimated minute volume divided by the tidal volume. Now you have tidal volume. Now I'll cover this and then I'll go back to minute ventilation. Okay. Tidal volume you can set at anywhere between 6 to 8 milliliters per kilogram, or 8 to 10 milliliters per kilogram, or 10 to 12 milliliters per kilogram. It goes, I'll explain further, just let me get through this, stay patient, I'll explain it, don't worry. Now when I say milliliters per kilogram, it's of ideal body weight, not their actual body weight, because as a person grows more obese doesn't mean that their lungs are also getting bigger and bigger to compensate. No, the lungs are the same, the heart's the same, they might be a little bit bigger because there's a lot of fat around it, but other than that, the organs themselves are the same, just like bones don't grow. Not everybody's big bone. No, we're all the same bone. If you look at an x-ray of a really obese person, you see their frame, their skeletal system is the exact same as Channing Tatum, for example. Tidal volumes as low as 6 milliliters per kilogram are described and prescribed by the ARDSnet, Acute Respiratory Distress Syndrome.net. That is their protocol. Low tidal volumes, high respiratory rates, and keeping the plateau pressures below, ding ding ding, 30. Yes, so we've covered that very extensively in class. That is to minimize the pressures and to prevent any kind of barotrauma or lung injury or any of that nature. For COPD patients, since they have air trapping, which leads to a increased expiratory time, they need a longer period of time to exhale that breath, exhale that volume. If you set a certain tidal volume and they can't breathe it all out in that time, it leads to auto PEEP. So for COPD patients, do about 100 or 200 milliliters below what you originally set, like 6 to 8 if you set your criteria according to 6 to 8, knock it down about 100, 200 milliliters. Now, when you set a tidal volume on the ventilator, is that ventilator actually delivering that exact tidal volume? Let's say if you set 500, is it delivering 500 like from the machine? Is it giving 500 to the patient, or is there some lost in the vent circuit? Yes, there is some lost in the vent circuit. The tidal volume set is not exactly what it delivers, that what comes out from the to-patient port and comes back to the from-patient port. Because gas leakage in the circuit, you have gas leakage at the endotracheal tube, and also due to the circuit compressible volume, which is 3 milliliters per centimeter of water, times the PEEP minus PEEP. So if you have a PEEP of 60 and a PEEP of 5, for example, 60 minus 5, 55 times 3. Well, let's just make it. You have a PEEP of 55. You have a PEEP of 5. So PEEP minus PEEP, 50 minus 5. 55 minus 5. You have 50 times the 3 milliliters per centimeter of water. So that's 3 times 50 is 150 milliliters is lost in the circuit of it compressing and decompressing per breath given. So therefore, let's say you set 500. The patient is definitely getting that 500 because the ventilator knows this circuit compressible factor. So it delivers, 150, so 500 plus 150, 650 milliliters is what the ventilator is giving from the to-patient port. Now, by the time it goes from the to-patient port to the ET tube down into the lungs, it has lost 150 milliliters according to the circuit compressible factor, and therefore only delivers that set tidal volume of 500. Yeah, that's a lot. Okay. Then you have your FiO2. You can set that at, initially you can set it at 100%. If you don't know what they were on, let's say in the ER, you're like, hey, Joe Schmo, respiratory therapist, what were they on in the ER? You're like, I don't remember. Okay, put them on 100%. Evaluate their saturation, see how they do. You don't want to leave them on 100% oxygen for more than 24 hours. You can lead to O2 toxicity and a lot of different random effects go to that. You can do oxygen washout, which could ruin the recruitment of the lungs because it blows out the nitrogen in the lungs that keeps the alveoli open. What else? So evaluate the patient on, they're on 100%, they're satting 100, turn it down. Keep turning it down till you see a significant drop, and then turn it back up a little to make sure you keep your saturations within your protocol, above 90%, or above 60 millimeters of mercury if you're doing the ABGs, if you're trending via ABGs, which is... let's see. If the patient is stable, if they're not at significant risk of desaturation, put them on a FiO2 of less than or equal to 40%, and either titrate up or down depending on how their saturations do. And if the patient, like I said, they came up from the ER and you needed a tube and you put them on a vent. If Joe Schmo, respiratory therapist, knows, okay, they were on 36%, they were satting 100%, they were doing great. So you put them on a ventilator, dial in 36%, you are good to go. And remember, to determine your oxygenation and your ventilation status, always do an ABG after 15 to 20 minutes after you've set the person up on the ventilator. No more than 30 minutes max. Your PEEP, positive end expiratory pressure, you set at 5 foot long. That's what you set it at, 5. You can change that to higher or lower depending on your ABG results. If you have them on 60% FiO2, but their PaO2 is still not where it should be for a FiO2 of 60%, increase the PEEP, help them with their oxygenation, increase their FRC by increasing the PEEP, which would help in refractory hypoxemia. Refractory hypoxemia is hypoxemia that does not get better with oxygenation, like delivery of oxygen. Let's see, what else? I think that's it for PEEP. 3 to 5 is the normal range for PEEP. You have some doctors that prefer 3, some that prefer 4, some that prefer 5. Some hospitals are under protocol the therapist gets to pick, so they set them on 5 and then lower or increase depending on their oxygenation, depending on how bad their lung recruitment is, if they need to, if they need some help keeping the alveoli open. It just depends on the situation, but normally 3 to 5 is PEEP. Your IE ratio, inspiratory to expiratory ratio. Normally it's 1 to 2 to 1 to 2, and it can go as high as 1 to 4 or upwards. Normally you would not want a IE ratio less than 1 to 2. The IE ratio can be regulated by the flow rate. It can be regulated by the I time, if your ventilator has that option to change the I time directly. It can be regulated by the E time, and it's also affected by the tidal volume and respiratory rate. If you increase the flow rate, actually scratch that. You have your I time, you have your E time, right? Those will always be inverse of each other. For example, if your I time increases, your E time will decrease. Likewise, if your I time decreases, your E time will increase. They're inverse of each other. It's like, okay, this might be a very crude example, but you have 2 balloons. Only one is filled up completely. You put them both together. What happens to it? They stabilize. The one balloon that's completely filled up will decrease until both of them reach a equilibrium gradient of the air between them. Now, if you squeeze one, if you make one smaller, the other side will become bigger. There's no way that if you squeeze one, the other will also become smaller. It's not possible. They're inversely related. So if you increase one, you decrease the other. If you decrease the other, you increase one. Now that we have that set. Flow rate, how fast you can get the air in. If you increase the flow rate, you will increase the IE ratio, which means you will have a higher IE ratio. You will have 1 to 3, 1 to 4, 1 to 5, 1 to 6. If you lower it, you will have lower, 1 to 3, 1 to 2, 1 to 1. And you can have decimals between there also. If you increase your tidal volume, you will decrease your IE ratio. So if you go from 500 to 600, your IE ratio will decrease. It will go down 1 to 3 to 1 to 4. 1 to 3 to 1 to 2. And vice versa. If you increase your frequency, your IE ratio will go down. Let's say they're breathing a 1 to 4 on a respiratory rate of 14. You take down the respiratory rate to 10. You increase the respiratory rate and their IE ratio goes down from, what I say, 1 to 4 to 1 to 2, for example. Now, there are some formulas, I'll put them here somewhere. I'm just going to briefly describe them. You could also use flow, which, to determine the flow that you need to achieve a desired IE ratio. You could do flow equals minute volume times the sum of the IE ratio. If you need to know just the I time, I time equals the time for each breath times the I time percentage. And the I time percentage is the inspiratory ratio divided by the sum of the IE ratio. Now you have your flow patterns. I'll put them up also. You have your square wave, which is used for diagnostics. You have your ascending wave, which is better for partial airway obstructions. You have your descending wave, which is better for the distribution of tidal volume and gas exchange, mainly in COPD patients. You have your sine wave, which is more physiologically correct, because we don't all breathe. We breathe like a wave, like a sine wave is, like, you know. Okay, now we go to the vent alarm settings. These are pretty straightforward. I'm going to go through them real quick. There's nothing really to explain, I guess. It's just settings. You have your low exhaled volume. You set that 100 less than what they're expiring, what they're breathing. You have your low inspiratory pressure alarm. You set that 10 to 15 less than your observed peak inspiratory pressure. You have your high inspiratory pressure. You set that 10 to 15 above your observed peak inspiratory pressure. You have your apnea alarm, which is about 15 to 20 seconds. Your high frequency alarm, your high rate alarm, your high rate alarm, 10 above your observed frequency. If they're breathing 15, set your alarm at 25. If they're breathing 10, set it at 20. Your high and low FiO2 alarms. I haven't seen this on the PB840, but it's mentioned in the text, so I'm mentioning it on the video. 5 to 10% above and below their analyzed FiO2. I'm assuming that they have a O2 sensor at the I don't know really. I'm just gonna ignore that. Okay, now that we've covered the indications, contraindications, the initial vent settings, the vent alarm settings, now let's cover hazards and complications with mechanical ventilators. Now all of these are relative. They're not absolute, like, okay, if this happens, this, you know, they're relative. Relating to positive pressure ventilation, you have barotrauma. That could be caught. The risk of that increases when the PEEP is increased above 50, when the plateau pressures are above 30, and when the mean airway pressures are above 30, and when the PEEP is above 10. Positive pressure ventilation also affects cardiac output, decreases cardiac output, which in turn decreases blood pressure, which in turn decreases the delivery of oxygen to the tissues. So you gotta be careful if they've already got a low blood pressure, low heart rate, and you put them on positive pressure ventilation and they bottom out on you. Be prepared to know that it could be due to the positive pressure ventilation. It could be due to the, some complications could be due to the patient's condition. Maybe they have organ failure, which is pre-existing to the mechanical vent. It could be due to infection. They could have MRSA, septicemia, all kinds of stuff. It could be related to ventilator, or it could be related to the artificial airway, such as they pull it out, accidental extubation. Well, they pull it out, that's not accidental, but you know, we call it accidental because they don't know what they're doing. Endotracheal tube blockage, if you have a mucus plug or if you have some obstruction in the circuit. It could also be related to, some complications arise from medical professionals themselves. Nosocomial pneumonia, such as VAP, ventilator-associated pneumonia. You could get that from the therapist or the doctor or the nurse breaking the circuit too many times, allowing for the pathogens to get inside that circuit and right down to the lungs, causing VAP. And inappropriate vent settings. Like I said before I started the vent settings, if you don't know what you're doing, don't do it. If you mess around, this is an invasive procedure. You can damage somebody very fatally, I suppose. So be knowledgeable in what you're doing, practice safe ventilation, I guess, and that is it, boys and girls, for tonight. I think I'll leave you with that. Practice safe ventilation. The notes are in the description below. If you want to subscribe, that'd be great. If you have any comments, concerns, leave them in the comment section below. How I can improve these videos. That's about it. Thank you guys. Have a good night.